with the beautiful background.
Yes.
We knew we couldn't start without the beautiful background.
There we go. Well, it's backwards. So.
Dr. Peterson, better late than never, believe me. And
Sorry.
I'm the last person in the world that should ever say anything about anybody becoming late, believe me. Anyways, I want to welcome everybody here. My name is Howard Blumenthal, and we're here to learn a lot today. I'm here to moderate for a panel that we've got, and actually, in speaking to the panelists the last couple of days, I think this is going to be one of the better webinars that has happened during this pandemic. First off, we're going to have Dr. Paul Chu. He's a board-certified interventional pain management specialist, anesthesiologist, and he's the owner of Vanguard Interventional Pain Specialists. He's going to lead us off with an examination of PRP therapies, which myself, as a plaintiff's attorney with the Barnes firm and having practiced for 25 years, it's cutting edge stuff, and I'm sure you guys are going to learn a lot from that. We also have Dr. Jamie Curran, and Dr. Curran is going to be very interesting to all of you. He's a licensed naturopathic doctor, ND, not MD, and we're going to have him talk about that a little bit. Center for Medical Cannabis Education, and he's going to give us information on the regulation and use of cannabinoid treatment for both pain management and orthopedic modalities. He's also going to give us his background, which I find very interesting, which is something that I think this is an area that a lot of our clients have talked about and want to ask their attorneys, is this something I should be doing on pain management? And Dr. Curran's going to help us understand that and hopefully expand all of our practices. We also have with us Matt Alave, and he is, once again, a very interesting individual. He's a licensed acupuncturist, but don't call him doctor. But when you talk to him, you're going to think he's a doctor. You're going to think he's got like 3 MD degrees. So when he speaks today, he's a traditional Chinese and sports medicine specialist with Active Med Integrative Health Center. And he's going to take us through non-invasive Axon Therapy for treatment of chronic pain. And I hope he's also going to share with us the way he does acupuncture, because in listening to him speak, you're going to want to use this type of acupuncture for your patients, because the other doctors have said it's also something that they do in their work, which includes Dr. David Peterson. He's here to talk about advances in orthopedics, spine, and stem cells. He works with Gold Coast Orthopedics and Spine. Anytime during this webinar, if anybody has any questions, feel free to put questions into the chat, and I'll try and make sure that the panelists get a chance to answer those. We're going to try and make this move as quickly as possible, but give the panelists enough time to let you guys know what's going on. And we will have some time at the end for question and answer. And with no further ado, I'm going to hand things off to Dr. Chu to get us started. Dr. Chu?
Okay, thank you so much, Howard. Thank you so much for this introduction. And it's a pleasure to be here with everybody and taking the afternoon to learn some of the new advances in pain management. So let me share my screen first. All right, so my name is Paul Chu. I'm an interventional pain physician. My practice here is Vanguard Interventional Pain, located in Humber, California. And I've been doing interventional pain injection for probably close to 18 years now. So we're gonna be talking about that platelet-rich plasma, the short for PRP. Let me see here. Why is not moving? Okay, so PRP has been used since the 70s, and it was mostly used early for celebrities and that star athletes to help them recover from their injuries. The theory behind that is that, well, there's a lot of nutrients, healing factors within our blood that's supposed to help us to heal. And if we concentrate those substances and deliver that to an area of injury, that should promote healing. So lots of athletes and whatnot have done that in the past, and the result has been amazing, and gradually trickled down to more of the normal lay population. Of course, now we have used this for many different conditions, and that is truly a very effective therapy that for someone who prefers a holistic, non-invasive way to have better pain relief that use our own body's growth factors. I think this is a wonderful type of therapy for anybody who suffers from chronic pain. So what is a PRP? PRP is basically our blood carries factors, growth factor, platelets, red blood cells. We tend to see that red blood because that's what how the red blood cell looks like, and it carries oxygen. But there's a whole host of other factors that sometimes gets forgotten. And the PRP, what it does is that it basically centrifuges the blood and separates by different weight and sizes. So at some point, it collects a fluid here, the yellowish fluid, which is plasma, and a little buffy coat, which contains all the nutrients there. And what we do is we'll collect this little nutrients, which contains factors such as platelet derivative growth factor, the transforming growth factors, the vascular endothelial growth factors, the epidermal growth factors, fibroid blood growth factors, and insulin-like growth factors. All those promote different types of cell growth, tissue formation, and that helps overall in healing. And that on areas, for example, in the joint, on the ligament, where there's very little poor vascularization, that meaning there's not too much blood supply to the area. Well, if you think of this, the blood is where it contains all these factors. And if you have poor blood supply, then those factors will have a very limited amount arriving to those areas that are injured. So by concentrating this type of growth factors, healing factors, and deliver directly to the area of injury, of course, that enhances the chance for a faster recovery. So this cascade of this healing basically is a coagulation healing. The platelet gets activated, and due to the inflammation in certain areas, and then different factors starting to go into places and help to increase some of the cleaning and the reforming activities. All those factors that we named earlier. At the end of the process, of course, the cause is a new remodeling and a healing of the tissue that is appropriate to the area there. What conditions have we used this in? Mostly tendon injuries, joint injuries, any kind of arthritis that we also have used that. Sprained ankle, tennis elbow, and we also use acute injury and muscles. So hamstring, pulled hamstring muscle, sometime from automobile accident where you have this whiplash and some of the muscle are strained. Then that would have been used a lot. Of course, osteoarthritis and the knee joints, elbow joints, shoulder joints, and spine injuries. We have done a lot recently. Personally, I've done quite a few of epidural injections. Instead of using steroid, we use PRP, and we also have used facet joint injections for patients who are perhaps prefer the more holistic way, more natural way, or a patient who, for other reasons, cannot tolerate steroid, which is usually commonly used for this. And the result has been phenomenal. In fact, I have a patient that I've done pretty much everything with the steroid, and we decided that maybe we should give a try with the PRP injection to the facet joints. And it turns out that that's what gave her all the most relief of everything. And some of the doctors after surgery, for example, inject PRP in the area of the surgery to promote healing. So all this has been shown in multiple case reports and articles that it helps with this, but there's still no head-to-head comparison or randomized studies to give a more definitive answer in terms of the results. So how do we extract this PRP? As I mentioned earlier, we collect the blood from the patient self, and then with that, we centrifuge about 3,500 RPM for about 15 minutes. and that will separate both of the plasma and the red blood cell. And then from there, we collected all the plasma and the buffy coat. And once we collect that, we'll inject to the area under fluoroscopic guidance if it's a spine, or ultrasound guidance if it's just soft tissues, a joint, whatnot, and to the affected areas. Is there any potential side effect? Of course, any injection, any kind of procedures that requires pierce to the protective layer of our skin has the chance of introducing infections. So that's always a possibility. Nerve damage, not necessarily directly from PRP itself, but if someone who's not very careful and inject right on the nerve, that could cause a shared, trauma to the nerve. However, most of these procedures done under just local anesthesia or no anesthesia at all, because the needle is very fine. Anytime we get close to the nerve, before you even get to there, patient will react very severely. So you know that you're not in the area. And just like any injection, afterwards you feel a little soreness and that in the area of the injection, even like right now the COVID vaccine, the arm gets sore. That's pretty sometimes normal reaction rather than anything else. And tissue damage, as I said, unless it's something very confined area and once inject a large volume to the area, confined area, it's very unlikely to cause any kind of tissue damage. So these are the potential and some of the risk that is there, but I have never seen it happen in the hand of any very well-trained physician performing this type of therapies. What is the recovery time for the PRP injection? Well, I think the injection itself, sometimes patient may feel immediately a little bit of a soreness in the injection area, and that usually goes away within 24, 48 hours. But the healing process, it takes time. And based on my experience, I think is that the healthier the individual that is, that the donor of their own cells, then the better quality those PRP can contains more factors, then the healing is much faster. But usually we tell them that once start noticing some relief, maybe 2-3 weeks into that, and may take up to 2 months for us to feel somewhat of the improvement on the area. And it's not something that like a steroid injection within 24, 40 hours, you notice a good improvement. This has come rather suddenly, slowly, you find yourself, oh, well, I can, certain activity I wasn't able to do or raise my arm, now I can raise a little higher. So gradually it gets better as the tissue continue to heal naturally. Contraindications. So what are the perhaps the patient population cannot be accessed to this type of therapy? Someone who has abnormal platelet function, very low platelet function, platelet count, then probably there's not enough to collect. Same thing that applies to anemia, cancer, and of course anybody who has a infection in the system. That is probably not a very ideal situation, right? For candidate to extract the blood and then of course spin it down, because you could probably introduce more infection, whatnot. Effectiveness. Studies shown that after about 24 weeks of comparing the PRP and with the steroid injection, actually about 84% of patients who had received PRP reported good 25% reduction in pain, while the group that received steroid and the same amount of time was only report about 68% of them reports that. Okay, and there's some study has shown that maybe the PRP can last. It's not a permanent cure of the problem, but it actually to help to enhance or hasten the recovery. So sometimes people said that may last anywhere from 6 to 9 months, and if it's a chronic condition, chronic inflammation, for example, arthritis, maybe requires additional injections within the next 6 to 9 months. But usually within about 6 month period, we don't in our practice do more than 3 injections in the same area within about 6 month period, because we want to really allow the area to heal. and take advantage of this. And also bear in mind that this is can only work with what you already have. So if it's an acute injury, it will enhance the area to the healing. But if it's something that someone who has a bad arthritis where the joint is already completely worn out, this is not going to regenerate the joint, the cartilage, whatnot. It's just not going to happen. May feel temporarily relief for a short period of time, but it's not a cure of the problem. So yes, patient selection and also expectations of this is very important for them to understand it and understand the success of this type of therapy. Despite a vast amount of supporting studies, researches with this therapy, unfortunately, at this moment, insurance companies still consider PRP therapy as experimental. So most of the time, it's not covered by any insurances, and that a patient would have to, pay out of their own pocket for this therapy. So at the end, do we think this is safe? Of course, I think it's a very safe because it's a autologous therapy. So it means that there's no foreign material that's introduced to your own body. So there's chance of any kind of adverse reaction, allergic reaction is pretty much non-existent. Okay, and there's also an added benefit of this is that it's not just that reduce the pain or reduce the inflammation, but it does a lot more than that. It has that potential to heal the area, small area with perhaps very tissue damage. It can be promoted to heal better than the steroid, because steroid, what it does is reduce the inflammation, but it doesn't promote any healing, and the healing still requires our body own process to regenerate some area, and some area who are, for example, the joint or the ligament tendons are very poorly vascularized. Those areas may not necessarily heal after the steroid injection because there's not enough of blood perfusion to help that. Okay, so the other benefit I think is that because this is very natural and that helps in order to minimize the use of any external oral opioids or anti-inflammatory medications that sometimes carries other very detrimental side effects, whether it be dependency or some people who just have other conditions where steroids or non-steroidal medications will cause them to have problems with the kidneys or other organ functions. Lastly, even though this is a very good therapy, again, it depends a lot on the individual and also on the type of injury. If it's a full torn, complete torn ligament, probably this is not a therapy that you have to use. I think that's a surgery, so we have to be realistic. It's not just this is a silver bullet that can cure everything. However, for the right condition, right patient population, this is definitely probably superior by compared to any kind of injection such as steroid or non-steroidal type of agents. Okay, so this is a very quick summary of what the PRPS is, and that I'm open for any kind of question or anything whenever everyone has. Thank you so much.
Dr. Chu, real quick, Kobe Bryant, I think, was the first person that I remember bringing PRP to our attention when I think he went overseas to Europe and had it done for his knees. Can you kind of explain briefly what he was trying to do and what he got out of that?
Okay, well, we know that he had it. I don't recall exactly what year was it, but at that time, of course, that was still very sort of unreachable for most of the people in the United States. And Europe, for years, they have always been very, I guess, open to new technologies or new application for them to use. So he researched, I'm sure Kobe researched that this is the best thing he wanted to do, because he wanted something more natural to help promote healing and more that can actually improve his state rather than, for example, steroid injection. Because so we know that if you dissect the tissue with steroid injection, sometimes you have a calcium or calcified deposit, which for any of the being tendon, being a cartilage, those calciums eventually can worsen the condition, especially in a high level athlete as Kobe was. He wanted the best for him. So I'm sure having the resources and all the expert around him to advise him what's the best therapy for him, he chose the PRP.
Okay. One other question. In your practice now, what body parts are you using it the most in your personal injury cases?
We use the most for knee and shoulder injection. We also use it on spinal epidural injection and facet injections. But most by far is our shoulder and knee injection.
Okay. I don't think we have any questions right now. So what we'll do, thank you, Dr. Chu. That was very informative. Next up, we're going to have Dr. Curran. And as I mentioned earlier, Dr. Curran has a very interesting background, and I'm hopeful Dr. Curran will give us a little bit of his ND background, because I think everybody should understand that this naturopathic doctor that he is, in many states is the equivalent of a doctor. And in California, I think you were telling me, Dr. Curran, that it's similar to a nurse practitioner or a physician's assistant. So what you're going to be talking about here, cannabis, is coming from a solid medical background. Dr. Curran, can you give us a little bit of that before you jump into your presentation?
I will. Thanks, Howard, and thanks for being here. My name is Jamie Curran. I'm a naturopathic doctor, as Howard mentioned. I also have a master's in public health. I do clinical research. I have a small specialty clinical practice where I help patients use cannabinoids from hemp and marijuana to treat a wide variety of symptoms and medical conditions, primarily pain, but also anxiety disorders, sleep disorders, seizure disorders. Not many people know what a naturopathic doctor is. I think there are 25, maybe 27 states that have licensed NDs. We go to a 4-year medical school. I did a 2-year residency. The scope of practice in each one of these states varies. It's typically, naturopathic doctors are typically classified as physician level providers, where they have a scope that's similar to DOs and MDs. In other cases, they are classified as mid-level practitioners, where they have a scope of practice that's more similar to nurse practitioners or physician's assistants. In California, we are mid-level practitioners. So I am going to try to cover a lot of ground here. There's a tremendous amount of confusion when it comes to medical cannabis. So I will get to it and probably go pretty quickly. I should mention that I advise companies that manufacture and sell products that contain CBD. And here are basically the 3 areas we'll focus on in this presentation: regulation, mechanism of action as it relates to anti-nociception, and then we'll look at some research. So part of the confusion relates to the terminology. Cannabis sativa is the botanical name for this plant, and cannabis is the genus and sativa is the species. Marijuana and hemp are simply common names for this plant. Because of the historically pejorative use of the term marijuana, currently many people will substitute the term marijuana for the term cannabis, but they'll use a lowercase c and they won't italicize it. Whereas the genus, when it's written or referred to, is capital C and it's italicized. Now, it's pretty confusing because hemp is also cannabis. So some people will say hemp this and cannabis that, but nonetheless, that's the prevailing terminology for now. This plant is thought to produce over 500 biologically active compounds, including a class of compounds that are called phytocannabinoids, of which THC and CBD are the most well known. From a regulatory standpoint, marijuana and hemp are distinguished from one another by their THC content. Now, this is the definition of hemp from the 2018 Farm Bill. You'll see that it refers to the plant cannabis sativa and cannabinoids, et cetera, et cetera. and it refers specifically to a threshold of THC. So if plant material has less than or equal to 0.3% THC by dry weight, it's a hemp plant. If there's more than 0.3% THC, then it's a marijuana plant. And so you would only know whether you're looking at a hemp plant or a marijuana plant if you were to chemically analyze the constituents and measure the concentration of THC. You may have heard that the FDA approved a drug in 2018 in June. The drug is Epidiolex. It is a highly purified extract from cannabis, purified to the point where it's basically 98 or 99% CBD. It was approved to treat 2 rare forms of intractable epilepsy. Now, what you see all over the internet and in a variety of different stores, gas stations, health food stores, et cetera, are these over-the-counter CBD products that are mostly derived from hemp, that are sold and marketed as dietary supplements, even though the FDA maintains that they are not, in fact, dietary supplements. In fact, the FDA says they are excluded, and this I'm referring specifically to CBD. CBD is precluded from being a dietary ingredient because it's already an FDA-approved drug, and you can't put an FDA-approved drug into the food supply or into a dietary supplement. And this is quite confusing because of the widespread availability of all of these products. So just to be clear, every product that you see out there is in violation of FDA regulations, unless it's an externally applied product like a topical product. And this obviously needs to get sorted out. I published a paper in 2018 with a prominent cannabis attorney on the very confusing regulatory status of CBD. If you email me, I'm happy to send you a copy of this paper. So these compounds that are produced by the plant are fat soluble. They can be extracted using various methods. And because they're fat soluble, the extract is an oil. So it's typically rich in CBD if the starting material is hemp, or it's rich in THC if the starting material is marijuana. And as I mentioned with regard to Epidiolex, these extracts can be purified to a greater or lesser degree depending on the desired finished products. Highly purified extracts like Epidiolex are referred to as isolate. So if you hear CBD isolate, it's referring to something that is basically a single molecule drug product or a single molecule, quote unquote, dietary supplement product. Now, cannabis advocates will say that these CBD or THC isolate products are inferior to less refined extracts because they lack the possibility of interactions between all the various constituents in this plant matrix. And it's thought that these interactions could lead to a synergistic effect that would be different than the effect mediated by a single molecule. And this is affectionately referred to as the entourage effect. And the basic tenet here is that you can use a lower dose of CBD in a full spectrum extract, let's say, as compared to a highly purified extract or a CBD isolate product, and get the same therapeutic outcome with a lower risk of adverse events. Now, whether that's true or not really remains to be seen. There is some meaningful research that shows that there's a signal here. I mean, this is truly a pharmacological phenomenon, but how relevant it is to clinical practice really remains to be seen. And there's so much mythology in this space, and there's so much noise, so it's difficult to know what's true and what's not true. I am going to blow through the endocannabinoid system, given the time constraints. Everyone is, well, most of you have probably heard about this. It's often referred to as a master regulatory system that restores the body to balance or homeostasis after some sort of disruption. The main components of this system are 2 G protein coupled receptors, CB1 and CB2, and the endocannabinoids themselves. The first and most famous is called anandamide. Ananda is the Sanskrit word for bliss. The chemical name is arachidonyl ethanolamine, or AEA. It was the first endocannabinoid discovered in 1992. The second is 2-arachidonoglycerol, or 2-AG. And these are lipids. In the nervous system, they're effectively fatty acid neurotransmitters, which I will show you. The other components of the endocannabinoid system are the enzymes that both biosynthesize endocannabinoids and then hydrolyze them or degrade them, and then transport proteins that shuttle them in and out of cells and in the blood and in the intercellular fluid. So THC and CBD interact with cannabinoid receptors very differently. AEA, 2-AG, and THC are high affinity partial agonists of the CB1 receptor, and they bind to an orthosteric site on the receptor, which activates the receptor and initiates a biochemical cascade inside the cell. CBD, on the other hand, binds to an allosteric site on the receptor. So the takeaway here is that CBD does not activate cannabinoid receptors. In binding to this allosteric site, it changes the conformation of the receptor or the shape of it in such a way that reduces the affinity for all of these other agonists like THC, 2-AG, and AEA. And so you may often hear CBD described as a functional antagonist, and you may hear that it offsets some of the effects of THC, and this is the mechanism by which it may do that. But CBD does activate other receptors that are not considered part of the endocannabinoid system. Since we're talking about pain and inflammation here, the TRPV1 receptor is an often talked about target when trying to explain how CBD may mediate an analgesic effect. And so CBD is an agonist for TRPV1, TRPA1, and a variety of other non-endocannabinoid system receptors, enzymes, transport proteins, etc. So with regard to this regulatory function of the endocannabinoid system, I'm going to provide two examples. The first one is immune regulation. And here we have a diagram of the gut. This is a cross-section of the gut. Here is the lumen. Here's the bowel wall. And we have a mast cell and a macrophage. These two white blood cells have infiltrated the bowel wall in the presence of inflammation. And the macrophage starts to synthesize anandamide. It's producing anandamide because of the inflammation. This anandamide diffuses and binds to CB2 receptors on the white blood cell, which leads to a reduction in the production and secretion of TNF-alpha and other cytokines. So this is autocrine regulation. Anandamide can diffuse over to that mast cell and do the same thing, which would be paracrine regulation. It also diffuses down here and binds to a CB1 receptor on a neuron from the myenteric plexus. So immune regulation in the endocannabinoid system is mediated by CB2 receptors right here on white blood cells and leads to basically a shutting off or a reduction in the production of inflammatory mediators. And that's the story basically of the CB2 receptor. With regard to neuroregulation, that's pretty much a story of the CB1 receptor. Here on the left, we have those same white blood cells. And then on the right, we have a single stimulus, like a pinprick to the finger. It causes actual tissue damage. Cells release their contents. The inflammatory cascade begins. And this mechanism that we just described in the gut is actually happening here. So anandamide is being synthesized. It's binding to CB2 receptors on white blood cells. It's reducing the production and secretion of those inflammatory mediators, which you probably know increases the probability of hyperpolarization, which would send a signal through these afferent neurons up to the pain centers in the brain. So one anti-nociceptive mechanism here is mediated through CB2 by reducing inflammatory mediators. The other one is through CB1, through neuroregulation. So here's this classic model of neurotransmission. The presynaptic neuron releases neurotransmitter into the synapse, binds to a receptor on the postsynaptic neuron. And that's our classic model. Endocannabinoids are synthesized on demand as opposed to ahead of time. They're not stored in vesicles. They're produced as needed, and they're produced in the postsynaptic neuron. This is a completely different model, and they diffuse in a retrograde direction up to the presynaptic neuron and bind to CB1 receptors, which basically causes an endocytosis of these vesicles. It acts like a shutoff switch, just like it did in the immune regulation slide, except here it's a reduction in, say, glutamate or other neurotransmitters, as opposed to inflammatory mediators. And then this same model of neuroregulation occurs on the way up to the pain centers in the brain. So the first synapse is between this first order neuron and the second order neuron in the dorsal root ganglion. And then the second synapse occurs in the thalamus, moving up the spinal thalamic tract right here. And then the second order neuron synapses with the third order neuron to go to various pain centers in the brain. And so each one of these stops is an opportunity for inhibition to occur through the CB1 receptor. And then it also occurs in the descending pain pathways, which are typically mediated through interneurons in the spinal cord via these nuclei, basically the periaqueductal gray, the nucleus raphe magnus, etc. I know that was very quick. Here's a summary slide, which I'm not going to read due to time, but those are the various mechanisms that I just described. So now we're going to shift gears a bit and look at some pain research. In 2017, the National Academy of Sciences produced a 440-page report. It was a systematic review of all of the literature related to medical use of cannabis. It was a panel of independent experts, and they concluded with regard to pain that there was conclusive or substantial evidence that cannabis or cannabinoids were effective for the treatment of chronic pain in adults. Now, as you probably are aware, there are more anecdotal reports of pain relief than you could possibly imagine. This is obviously a very weak form of evidence, but it is evidence nonetheless, excuse me. There are also cross-sectional studies that aggregate patient-reported outcomes. I published one in the Journal of Pain Research in 2017. Almost 2,500 respondents reported that they were using cannabis as a substitute for prescription drugs, narcotics / opiates, and then NSAIDs and non-opioid analgesics were two of the top 4 classes of medications that these respondents reported substituting cannabis for. I published a similar study in 2018 in the journal Cannabis and Cannabinoid Research. This one was focused on users of hemp-derived CBD products. And you can see that chronic pain and arthritis / joint pain were the most common reasons why almost 4,000 people reported using these over-the-counter CBD products. You may have heard of these population level studies. They get a lot of media attention. These are studies that show associations. There's no cause and effect relationship here, but they show associations between states that have medical marijuana regulations and various opioid related outcomes. And what they have found is that states that offer medical marijuana have opioid outcomes that are reduced in the form of prescriptions for opioids being written, hospitalizations for both abuse and overdose, and then associations with reduced opioid overdose deaths. And then finally, with regard to some clinical trials, these are by no means this is not a systematic review. I'm basically cherry picking a few studies to highlight some of the points that I've already made. This was a randomized, double-blind, placebo-controlled study in 177 participants with intractable cancer pain. The study drug here was a cannabis extract with CBD and THC in a 1-to-1 ratio. And the outcome here is the percentage of patients or participants experiencing a decrease in pain at various levels. So this is greater than or equal to 10% decrease in pain, 30% decrease in pain, 50% decrease in pain. And the primary outcome of this study was a greater than or equal to 30% reduction in pain. The light gray box is the placebo. The darker gray box is THC. So using THC, a little bit more than 20% of participants achieved this outcome, greater than or equal to 30% reduction in pain. This finding right here is kind of an anomaly in my experience, that THC would be equal to placebo, but there is so much mixed outcomes and heterogeneity in this research that you can see just about anything. But this darkest gray box is the study drug, THC and CBD together in a 1-to-1 ratio. Here's the average dose that these participants were taking per day, so 30 milligrams of each per day. And you can see with added CBD, more than 40% of these participants reached that target. Now, whether this is a synergistic entourage effect or whether this is just an additive effect, we don't really know because there's no CBD group here. This study was a randomized double-blind study in 97 adults with chronic pain who were concurrently taking opioids. What's different about this study is that obviously there's no control here, which is very important, but the study drug was a hemp-derived CBD product that was available over the counter. And these study participants took about 30 milligrams of CBD per day. So this is the same amount that the participants in the previous study took in terms of CBD, but there's no THC, or at least not any meaningful amount of THC in this particular study. Outcomes were pain and sleep related. They were measured at baseline 4 and 8 weeks. On the left, the intervention, or the 30 milligrams of CBD, reduced the average score on the pain disability index by about 4 points over 8 weeks. The PDI is a 70-point scale. And then the average reduction of almost 1 point was seen on the pain, enjoyment, and general activity scale, which is a 10-point scale. So these are pretty modest reductions in pain. Again, no comparison to placebo. But 53% of the participants reported that they reduced or eliminated their opioids, and 94% reported improvements in quality of life. This is the last study we'll look at, then I'll wrap this up. This is the CANBAC trial. It was just published this month in the Medical Journal of Australia. It randomized 100 patients presenting to the emergency department with acute low back pain. They received either standard of care or standard of care plus 400 milligrams of isolated CBD. So the first study was 30 milligrams of CBD, 30 milligrams of THC. The second one was 30 milligrams of CBD in a hemp-derived product. This is 400 milligrams of isolated CBD. Primary outcome was change in mean pain score on a 10-point scale. Here is figure 3, which depicts that primary outcome. And you could see that there was no difference between CBD and placebo. So there's a lot of inconsistency here. There's a lot of variability in terms of the outcomes, in terms of the study drugs. And this is a pretty good snapshot of the world of medical cannabis research right now. So in conclusion, cannabinoids from hemp and marijuana are chemically identical, but regulated differently. The entourage effect is a scientific phenomenon. The clinical significance is really to be determined. THC activates cannabinoid receptors. CBD does not. They are both anti-inflammatory and anti-nociceptive. THC is a better analgesic. I did not show that in any of these studies, but it is. And as I mentioned, the clinical trial data is mixed and pretty limited. Obviously, that has a lot to do with the restrictions that have been in place since the Controlled Substances Act was passed in 1970. We need more studies, and fortunately, with the easement of some of those restrictions, these studies are starting to come. Thank you so much for your time. Happy to answer questions whenever it makes sense.
Dr. Curran, real quick, before we transfer over to Eastern medicine, what are the most effective areas of marijuana use that personal injury lawyers should be looking into for pain management of their personal injury clients?
The most effective areas of pain management?
as it relates to using cannabis or CBD oil or anything in this area?
Sorry, Howard, I'm not sure I understand the question.
Cannabis can be used to control pain, correct?
Correct.
So what should personal injury attorneys, if they want to incorporate this, if they want to expand the types of practitioners they use in addition to orthopedic doctors and in addition to acupuncturists, what areas should they be looking to be able to use to have their patients use this for pain management?
Well, that's one of the problems. There aren't a lot of healthcare professionals that are educated in this space. One of the reasons why I do what I do is because there is a real need here. A lot of patients are afraid to talk to their healthcare provider, or they aren't afraid and their healthcare provider doesn't have any answers. And so I help educate patients and healthcare professionals. And in San Diego County, I'm aware of 3 people, including myself, that do this and have a real focus on this area.
And when you're doing that, what are you like, what would you recommend? What are you using for pain management out of the CBD products?
Well, it depends on a variety of different factors. I'm either using hemp-derived products, which are predominantly CBD, in patients that can't fail a drug test or can't run the risk of being impaired for any possible reason. And that's because those products are very low in THC, even though they do contain a little bit. And then I'm also using marijuana products. Marijuana products in California are available for the most part. And because they have more THC in them, they're generally better for pain, but there is a risk of impairment depending upon the person and the dose. And there's also a risk of failing a drug test. I will tell you that every single one of my patients comes to me and says, I don't want to smoke and I don't want to get high. And so the objective is to use cannabinoids from whichever source, depending upon their situation. And drug interactions, frankly, with CBD is a real risk too, not so much for THC. But, I try to fashion a treatment plan that includes products that will either be purchased at a dispensary or purchased online or at a health food store, depending.
Perfect. Dr. Curran, you along with all the panelists, if you can make sure your email address is put into the chat. There was somebody that wanted to get one of the documents that you referenced in your presentation. And thank you very much. That was very informative. Next up, we won't call him doctor, but he certainly has qualifications that make him sound like a doctor. Matt Alavi, welcome, Matt. Before we get started, Matt, when we spoke the other day, can you talk a little bit? I know that you're going to talk about the Axon Therapy, but can you talk a little bit about how you use acupuncture? Dr. Peterson kind of agreed with you the way you did it. Can you share a little bit about that?
Sure, Howard. Yeah, so I'm an acupuncture physician, licensed physician in the state of California. Can prescribe do labs, do imaging, prescribe imaging, and all that kind of stuff. But the type of acupuncture I was talking about is more a myofascial trigger point, also known as dry needling. So essentially what we do is we'll go into myofascial trigger points in the back and the muscles and the shoulder. We'll hit those myofascial trigger points and cause a twitch response. Many of you pain management doctors out there do this with wet needle. You inject some lidocaine or something in there, but we do dry needling. But what we'll do is we'll hit that point, we'll get a twitch response, there's blood flow rushing in there, there's growth factors, as Dr. Chu was saying, you're injecting platelets, we're drawing platelets there, we're drawing growth factors there. We're causing a total milieu of transforming beta growth factor coming in there, insulin-like growth factor 1 is rushing in there. So we're causing these things to change and remodel the tissue. I personally treat a lot of patients with disc bulges in the back and the neck. And so essentially what I'll do is I'll use the acupuncture, go right next to the transverse processes and hook up an electric stimulator to it. That frequency goes in the shaft of the needle down to the area where the disc bulge is. Will cause an anterior posterior flexion extension of the spine with a little bit of a twitch response. That causes the disc to move away from the needle, but also we're bringing those factors in. We're bringing growth factors, platelets, stem cells, IGF-1. We're causing dopamine and histamine and all these different chemicals to be released there to create a healing response. The beauty of it is it increases not only the healing response like the PRP does, but it decreases inflammation as well. And so you get dual benefit of decreasing inflammation and increasing the healing response at one time. And you can move the disc away from the nerve. Essentially, the type of needling we do is not every acupuncturist or even PT would do this. So we do something pretty specialized. If somebody has tendinopathy in the shoulder, bad tendonitis, labral tears, very, very small labral tear, we'll go ahead and take those needles and go into the shoulder. In fact, I was just doing it to myself last night because I just re-injured myself doing something stupid, lifting weights. But essentially, we go into the shoulder, hit the tendons, hit the ligaments, cause these growth factors to rush in there and stimulate the healing process. So we'll do a lot of that's a lot of what I do. I mean, hit tendonitis. Dry needling is basically taking the needle, going in and taking it out. Acupuncture, we can leave the needles in, put electric stim in there. And then also in traditional Chinese medicine, you're using channel theory. So you're doing points away from the area of pain, thereby trying to tell the body, hey, there's a problem in this area. You need to go fix it. So essentially, do something in the shoulder. I might do something in the opposite leg, and the patient has less pain in the shoulder, and we create that healing response. So that's the type of acupuncture I do.
Perfect. Thank you, Matt. And let's let you go right into the chronic pain and Axon therapy that you're here to talk about.
Let's do it. Come on, baby. Here we go. Can you guys see my slides here?
Your slide is up.
All right, here we go. So Axon Therapy, a novel approach to decrease chronic nerve pain. So my center is called Active Med Integrative Health Center, and we partnered with Neurolace Medical, who's the medical device company that owns this machine and that has come up with this therapy. So essentially, Axon Therapy was founded in 2011. There was a patent filed on this therapy, and a patent was granted in 2019. There's the clinical data we assessed in my office in 2017, the fall of 2017. So essentially, the company brought their device into my center, and we tried to do a clinical trial, pilot study, and also a data collection on what this therapy was doing for patients with chronic nerve pain. This device that we're using is an FDA-approved device for brain stimulation. So many of you out there have heard of TMS, trans-electromagnetic stimulation therapy for TBIs, for brain injuries. And this therapy has been used for that. This company has taken the same device, changed the coil, changed a few things in there. So we're changing the waveform, which I'll get into in a little while here. And we're using it for peripheral nerve damage. So the peripheral nerve damage has not been yet approved for use with the FDA, but it's under approval right now. And they just have been granted some pretty cool clearance here. So we've treated hundreds of patients plus in our center here, and we're treating both chronic nerve pain and myofascial pain. Myofascial pain would be off-label use for this. This is in your right-hand corner right there, the screen. This is what the device looks like. And it's actually behind me. I don't know if you can see it. This is the device right here. We have a computer. We have the main device here where the electrostimulation comes out of, and then we have the handheld or robot-held device right here. So I'm just going to go over a little bit really quick about how this therapy works. And for some of you that don't know about chronic nerve pain and how it works, I'm going to go over that. So damage to A beta fibers in the nerve cause chronic pain. So essentially, three fibers that we're going to talk about is A beta, A delta, and C fibers. Now, when somebody has damage to a nerve, you have trauma to the nerve, you can damage many different fibers on there. You damage C fiber, you initiate C fibers, but you damage A beta fibers. What will happen is you create a pain signal. So C fiber is active, A delta is active, you're going to feel pain. Now, A beta is always active when you're not in pain. So A beta is a fiber that is telling the brain everything's under control. You're all good. There's nothing wrong. Well, when there's trauma to that nerve, basically the A beta now can't give good signals to the brain, so the body's going to feel pain, and chronically. So for example, if there's damage done, a disc bulge, a traumatic crush injury, a blunt force injury, and there's no more trauma there, the trauma has gone away, the patient should heal and the pain should go away. But a lot of these patient subsets, the pain does not go away. And these A beta fibers are usually the culprit because they've been damaged and they're not allowed to give good signals back to the brain, and so forth. The patient has an activated C fiber and A delta fiber again, and they have pain. So essentially what this device does is it stimulates the nerve that's been damaged and it reactivates the A beta fiber. So what we're trying to do is tell the body everything's under control. This particular frequency and this particular waveform will reactivate that A beta fiber and give the body good signals again. So thereby, you're telling the body, hey, everything's under control. You don't have any pain anymore. And a lot of us know about CRPS and things that, you know, these patients develop, these pain syndromes that they develop, that nobody knows why they're still in pain. In fact, some of these pain syndromes, they spread. Somebody had an initial injury in their knee, and now all of a sudden they have it in their foot, and they don't know why, and it's a burning and neuropathy-like pain. So right here, you can see what the frequency is. This is a waveform, and we're going to go ahead and move on here. So we use this for patients with nerve injury due to trauma, chemical or physical. So if somebody, for example, had an injection of a medication or chemotherapy and they have damaged the nerves, we can go ahead and use this therapy for that as well. Neck and back pain with radiculopathy. So I'm using this quite often for neck and back pain with radicular pain, down the leg more specifically. We do use it for carpal tunnel, and we use it for CRPS, and also we are using it for migraine headaches. Now I'm going to go over some studies and some clinical evidence on this therapy just to kind of give you some proof on it. And then we'll talk about some case studies on how this actually works in real life in the clinic. So these are accretive treatments, meaning they are progressive. They get better with more treatment. And the more treatment we do, the better somebody gets. Initially, what we're finding is that you can get 50% sustainable pain relief after a month. So after a month of somebody being gone with the treatment, not having the treatment anymore, you can still sustain 50% in pain reduction, which is pretty significant, especially in these chronic pain patients with the nerve pain. Now, there's another study done here, and this 45% basically is done after one treatment. 41% was done after one treatment. So essentially, the patients had one treatment, and they got a 41% pain reduction after 3 weeks. So initially, they got the 45% right after the treatment, and then 3 weeks after that treatment, they did a follow-up and had a 41%. I'm sorry, at the end of 4 weeks out. They also did a sensitivity study, and in this sensitivity study, basically the surface area of pain was reduced as well. So 80% decrease in the surface area of pain. And how they did this study is they evoked a response in pain by taking an element and stroking the pain area on the patient. And these filaments that they use in the clinic can initiate the pain where the patient is feeling, and it brought that pain back up to whatever it was. It'll bring it back down, the therapy after treatment, at 40%. And then in the surface area of pain, if their pain was their whole arm, we're decreasing that by 80%, which is significant, very significant. So these are some more clinical studies on here, some bars and graphs to make it look cool so you believe it. And you got the 50% sustained pain relief, and we have 80 plus patients treated in the clinic with these studies. how we do these treatments are we initially do 3 treatments back to back. So if patient A comes in on Monday, we're going to do Monday, Tuesday, Wednesday. We're going to do 3 treatments in a row. If they have significant relief after that first treatment, we will continue. If they have no relief in their pain symptomology after 1 treatment, we do not continue treatment, and usually it's not going to work. Most of the patients that are coming into our clinic that we're treating and we do 3 treatments are getting sustained pain relief. Rarely we'll have somebody that does 3 treatments and it works amazing and then it doesn't work anymore. So most of those patients that do get benefit after 3 treatments, it will continue and they will get sustained relief. If anybody, and I'll put my website in the little chat there, and I'll put my email in if you want more information on this. I can send you all the studies. I can send you a lot more information on this device and what it does. But also, if you go to our website at activemedhealth.com, you can see some videos and testimonials on some people that have very bad chronic pain that have used this device and have gotten much better. Okay, so essentially just a real quick summary of clinical evidence on this. And in 2013, this was published in this Journal of Pain, and there was a patent granted for it. They did a random controlled trial of in 2016, and then they were granted FDA 510K pathway. 80 plus patients in 2020 treated with a certain protocol, and then there was a generation 2 that was created that we actually have in our office. And so now they're doing some studies on how they can make this a first-line therapy. So essentially using this therapy in conjunction with pain management, but maybe before some of this, you know, the hardcore opiates, some of the hardcore drugs, some of the surgeries and things like that first to see how well the patient responds. And then you can use those therapies as well, or in conjunction with. Some of these doctors right here are on the advisory board of this company. Dr. Leonardo here, he basically is doing a study out in North Carolina right now. And that is being done on, I don't know how many patients, but it's a lot of patients. They're doing a huge clinical study. And this is what's getting that FDA approval for peripheral nerve injury. So it's a very restorative and safe device. We're not really getting any kind of side effects. However, if there are some patients, especially with CRPS, that are very, very sensitive, and some of you know out there that a lot of these patients basically with the CRPS, if you even just touch them wrong, they're in an amount of pain. So typically, some of these patients can get a little bit aggravated with a treatment. If that happens, usually we do not continue treating with those patients that do get aggravated. However, in some of those patients, we can go distally or proximal based on where that pain is, and usually it's proximal. So for example, if somebody has pain in their foot, we'll go ahead and do some stimulation up in the upper calf, either on the tibial nerve or common peroneal nerve or whatever nerve that's going down at the foot to cause pain. So during some of these studies, basically, they're looking at 30%, 36% accretive pain relief, and then a greater than 50% sustainable pain relief, which is, most of you guys that know, pain studies and things like that, that's pretty good information. I'm going to give you a couple case studies that we've done here in the clinic here. And so this patient here was a 63-year-old female. She had a chief complaint of severe right lower limb and foot pain. This pain was due to a Marcaine injury, and she had this done in the hospital. Hit a huge amount. They gave her way too much. It was on a pump. They gave her way too much Marcaine and damaged the peroneal nerve, and she was in severe pain. She initially came into our office for acupuncture, and we did acupuncture with electric stimulation on her, and she got worse. And so we had the Axon Therapy device at that time, and we decided let's use this on her. And she would be in constant pain. So her whole right lower limb, especially on the lateral side, was in pain down on the top of her foot and her toes, even on the bottom of her toes. And she would be in incredible amounts of pain, even if the sheet would touch her foot. So some of you docs out there, you'll have patients like that where just touching something blows, the wind blows on their foot or their leg, there's a lot of pain. So we decided let's do this therapy on her. And so she was about 8 out of 10 pain, sometimes 10 out of 10. She had PT, she had everything done with her. During the first treatment, this patient was on our table and she started crying because she finally felt her foot feel normal, is what she said. And so immediately within, and by the way, these treatments are 15 minutes treatments with the stimulation. Sometimes it takes longer to find the area that we want to stimulate, but it's about a 15-minute treatment with the actual device per area. So this patient's pain level went down to 3 out of 10, and she had a sustained pain relief. She did the normal protocol of 3 back-to-back, and then 1 times 4, and then 1 every other week for 3 treatments, and then once a month for 3 months. After 3 months with no treatment, the pain relief was still sustained, and she actually became a spokesperson for the company. So she goes out and does talks for this company. I'll give you another case study. This guy, young man, 24-year-old man, he had severe foot pain as well. He was in a car accident and his foot was he broke his other leg. And then in the foot that he damaged, he slammed on the brake. And when he slammed on the brake so hard, he caused a lot of pain in that foot, swelling, and a sprained ankle, but nobody could figure out what was wrong with it. So they diagnosed him with CRPS. Anyways, gabapentin, topical THC, lots of medications, and he really didn't get any benefit from all that. But with that, and I did acupuncture 1 time on him, and I said, you know what, let's try this therapy first, because I think this therapy might be better for you. And sure enough, he got very good results. His pain level going down to a 3 out of 10. And if he's driving for long periods of time using that foot, he'll go up to a 5 out of 10. So it's really good therapy, works very well. It's 15 minutes long. Most of the patients that are coming in here right now are having very, very good results. And we won't continue treatment on them if they don't get results within that first visit.
Hey, Matt, couple questions. What are you billing that's the treatment at each 15-minute session?
So right now, because of the FDA approval pending, this is a cash pay. We have done a couple personal injury cases with this, but a lot of attorneys and a lot of doctors don't know about this therapy. So we haven't really done many PI cases with this therapy. But the initial visit is $375. And then basically going forward, it is $300 a treatment for this therapy. There's a cash pay discount at time of therapy. And so for cash paying patients that are coming in, we do the first 3 for $100 each, just to make sure that therapy is working. So we do $100 for the first visit. If you get no pain relief off of that, then we're not charging anymore. We're not doing any more therapy for the patient.
Okay.
So,
and is FDA approval, do you think it's looming in the near future, or is that
we're looking at a couple months. We're looking at a month to 2 months out with this therapy for that approval.
Perfect. Thank you, Matt, for the presentation. Last but not least, Dr. David Patterson from Gold Coast Orthopedics. Dr. Patterson, please take it away.
Hello, and thank you everybody for taking time out of your schedules to listen to us. Hopefully you're learning something. I have. I appreciate the other speakers. This is really important stuff. I'm going to get my presentation right here, if I can remember how to do it. And I got to start at the very end. I got to go back a bit, sorry.
While you're looking for that, Dr. Peterson, yeah. I'll correct your name. I'm sorry. There's a physiatrist in LA, David Patterson. So I apologize. Go ahead, Dr. Peterson.
You're getting a quick preview of everything. Sorry about that. I should have had Audrey just put it up. There we go. So beautiful start. Hopefully you can forgive the beginning there. But obviously, I'm going to go over the advances in orthopedic and spine surgery, some of the cool stuff, and then give you the good, bad, and ugly of stem cell therapy at this point.
So Dr. Peterson, we don't see your slides, but I can pull it up. So I'll do that for you right now.
Okay, not sure why that's not working. Thanks. My iPad, for some reason, is not cooperating with the Zoom anymore.
Okay.
So there we go. So hopefully, nice, beautiful picture. And again, advances in orthopedic stuff, spine, and then the stem cells. So I should be able to advance these or no?
I can control them on my end, yeah.
Oh, sorry. Okay. So those of you that know me, you've seen this slide before, but those that don't, I had a Navy scholarship for medical school, class president, the usual board certification. I've done that 3 times. Pretty proud of the no malpractice cases. And if you hit next, I do have 21 patents now. If you could next somehow. Don't know how to, there we go. And one at a time, please. Back, please. Oh, this is really, sorry about that. So I've trained over 1,000 surgeons in the United States how to do minimally invasive spine surgery. I've taught in Europe, several different countries. I've proctored surgeons at over 100 hospitals in the US, including Johns Hopkins, the Mayo Clinic, and about 100 other hospitals. I taught spine biomechanics at the PhD level at USF in Tampa, written book chapters, done all sorts of presentations and cadaver labs. And in the good old days, I did over 500 IMEs. Next. I'm going to today go over some general topics real quick. I'm going to touch on discectomy with annular repair, which I think is very important and needs to be done a lot more than it is currently being done. I'll touch on some novel posterior cervical and lumbar fusion techniques. My sacroiliac joint, I call it my baby because I kind of came up with this technique. I'll talk about that. I think in-office arthroscopy has a real important role, and I'll tell you a little more about that in a minute. And then there's a topic of disc nerve ablation, not facet joint ablation. And then, of course, like I said, good, bad, and ugly of the stem cell therapy. Next. Just a quick front and back of the spine and pelvis. And next. Then a close-up of this, you see the bone above and then disc and then bone. Those are a functional unit. You see the little yellow nerve coming out right at the disc level, and then a heavy ligament in the front that's white. And then if we just go next, you'll see the disc, the cord, the nerve roots, and the facet joints. Those are the heavy ligaments. Next, just to give you a feel for the anatomy. So if somebody has flexion pain, think of disc. And if they have extension or leaning back pain, it's facet-based in general. And the picture figure 4 there shows that if you load the spine unit, most of the force is absorbed by the disc when it's functioning. And then the facet joint also accommodates some load, but it's designed for motion primarily, not load absorption. So anything that damages the disc and keeps it from absorbing load causes damage to the facet joint, which is a pain generator in a lot of patients. Next. The nerve root hides in the upper part, as you saw there. So it's generally tries to get out of the way if there's a disc rupture, but it's not always successful. Next. So like I said, anybody that has a disc issue, they overload the facet and we run into problems with the facet. A lot of motor vehicle, et cetera, are facet-based problems more so than disc, at least in my practice from a surgical standpoint. There's certainly a lot of disc pathology, no question, but their facet gets overlooked quite a bit. And as a matter of fact, lumbar disc replacement was a huge failure. They thought they'd have 400,000 patients a year getting disc replacements, but they only have about 5 or 10,000 because 97% of patients that are candidates for disc replacement have facet disease, which causes them to fail. Next. Next, yep. So there's a huge difference between instrumentation there on the left and bone graft or fusion on the right. Primary bone healing is when you hold things rigidly fixed with rods and screws, and the bone slowly grows across the 2 surfaces. With the one on the right, it's secondary healing. We put bone in the joint that allows it to fuse, but there's some micro motion because there's no rods and screws, and we get callus formation, kind of like a broken arm in a cast. A much thicker, healthier, stronger bone and more flexible. We don't have as much adjacent level issue with the bone grafting as opposed to instrumentation. Next. Next. This is kind of a modern OR for spine surgery. There's a lot of equipment. We can actually do CAT scans during surgery now, where we couldn't before, using a fluoro machine, C-arm, and computer software. So it really has progressed quite a bit. It's not much room for the surgeon in there, but we do seem to squeak in somehow. Next. So in the treatment algorithm, 97 or 95% of patients are non-surgical. They get better with a lot of other treatment. You've heard some novel ways of doing it today. Then on the other side, the 0.5% is a major surgery. It's a very small portion of the people that get injured. And then if you go to the next picture, this is drifting toward minimally invasive surgery. And the numbers are increasing every year as to how many percent are starting to drift toward that minimally invasive. Next. If you look at minimally invasive, it's very attractive for a lot of reasons, but you have to be very, very careful on making sure that you know what the pain generator is. Otherwise, you're aiming that tube in the wrong direction and you're not going to help the patient. And SI joint is a typical example of why you need to be sure what the pain generator is before you do surgery. Next. So these two patients will both get better, but one of them, I guarantee, will get better a lot quicker. And the minimally invasive makes a huge difference. Next. So discectomy, which means removing the disc that's pressing on a nerve, it really needs to have every single time consider an annular repair. And I'll show you why. Next picture. So this is the unit, the blue dark circle around the outside of that disc is the annulus. The goo in the middle is the gelatinous nucleus pulposus. And of course, the spinal cord and nerve is behind that. Next. If you look at the two bones, L4, and then the lower one is L5, you can see the nerves coming out of the little lines. And then those circles with the yellow is a disc rupture that's on the side of the disc. And that affects the upper nerve root, the L4 nerve root. If it's the orange one, it'll affect the L5 nerve root down below. And if it's the brown one in the middle, it actually can affect both legs when the disc ruptures. So that helps us a little bit. MRI obviously helps us even more. Next. So this is the problem with the defense. They see a slide in a case report of somebody who has a huge disc rupture on the left. You see that big blob in the spinal canal and the red arrows around it. And then 1 year of what they call doing nothing, which actually was physical therapy and some other things, there was no surgery done, but that disc has dried out and basically disappeared. And so they claim that if you don't do anything, all disc ruptures get better. Well, of course, we know that's silly, but that's the kind of stuff the defense likes to point out and why your therapy is ridiculous. So just be prepared for that. That is in the literature. There's a lot of case reports of doing nothing and big discs disappearing. That is certainly not the rule of thumb. Most patients do have symptoms. Next. So old-fashioned, we would go in, make a hole, remove some bone, as you see in the detailed view, the little red semicircle, move the nerve out of the way, and then remove the disc herniation. This is somewhat unfortunate that we still have to do this, but for the most part, most of the disc herniations we can handle from a much smaller, minimally invasive approach. Next. So if we do a minimal discectomy on the left there, you take out a small amount of disc, but you have the area that you had to cut through the annulus to get to the disc. So that patient, if they do any lifting, bending, or twisting, they can actually, another chunk of that disc can go right out through and recur at that same level. If we do a subtotal, which we thought was the solution to the minimal disc removal, by removing as much of the disc as we could reach from that side, we thought we would have less recurrences. But then we have advanced arthritis that kicks in because we took away the shock absorber. So now the current thought is take the minimum amount of disc, repair the annulus so nothing can protrude, and we might actually preserve disc function, which would then obviously delay arthritis, etc. So a much better solution. Unfortunately, very few surgeons actually do annular repair. Next. It actually only adds about 5 minutes to the surgery. Next. The device goes into the disc, a suture is passed through one side, turn it around, pass the suture, pull it out, and tie the knot. It really doesn't take very long, and I really wish more surgeons would start doing it. I don't have any monetary benefit from that. I just think it's very good for the patients. Next. They tested this annular repair. You see the little blue line in the disc down on the right side, and they cycled it 85,000 times between flexion and extension. 1,500 newtons is about 330 pounds roughly. And so that's a significant load at one level to see if it would rip, and it held up very well. Next. And there's a lot of different kinds of disc annular repairs, and none of them has been proven to be any better than the other per se. Next. For posterior lumbar surgery, I'm going to talk about a bone grafting technique, not instrumentation. Next. So on the left is the gold standard, rods and screws. Still, most surgeons do that. On the right is a patented method of bone grafting, which is very stable. Although it's a flexible fusion, there is some mobility of the disc. And if you tap next, it'll show that if you put those pieces of bone, there's one missing, but next. Okay, so there's a lot of good reasons to do a posterior fusion with bone graft. The only reasons to use rods and screws are if there's a tumor that needs to be resected and you need to stabilize that area, if there's gross instability with a ligament tear, those sorts of situations, or a horrible angular deformity that needs to be corrected, that's a time to use rods and screws. Otherwise, if somebody has a disc herniation and minor instability, you can use the bone grafting technique. It doesn't burn any bridges, it's relatively low complexity, and it's very minimally destructive, quick recoveries. Next. So I'm going to go through a little bit of the science behind this and why I think it's so awesome, I guess. We use a tapered bone graft. In other words, it's sort of cone-shaped but angled. An undersized tunnel, in other words, I drill a hole that's smaller and then hammer in a bigger graft that separates the joint and holds it tight. Compaction reaming is a technique from ACL reconstruction where we take the edge of the bone of the joint that's good and solid, we drill it and create a tunnel. But when we do that, instead of creating sawdust that falls on the floor, we actually push the bone to make a solid wall for that graft to rest against. Indirect decompression is just positional. And then stress loading is very important for secondary bone healing. Next. So again, in this slide, if you go one advance just a little so that it'll show the next picture on this page. So next, yep. So the joint, when you drill the hole, there'll be a hole that's separated, kind of like the middle red picture on the left. And as the bone graft, which is tapered, starts to go in that hole, it realigns the joint. And then as it's hammered the rest of the way, next, you'll see the graft actually separates the joint, which then tightens the capsule on that joint and holds it solid. Next. And one more next. Yep. Thank you. The compaction reaming, if you drill a hole in the wall with the regular drill bit, you get sawdust all over the floor. If you drill it with the drill on the right, you actually will have no sawdust. The sawdust that's made from creating the hole is pushed into the edges of the hole itself, and it reinforces that wall for the bone graft to rest against. Next. Foraminal stenosis, if you bend backwards and you pinch the nerve, we forward flex, we open the neural foramina. So this is a way of indirectly decompressing without going in and removing bone. Next. Next. And we do it under fluoroscopy. Next. In the operating room. Skip this, please. Next. Yep. So cervical fusion, same concept. Go ahead. Next. The ACDF is what we're very used to seeing, anterior cervical discectomy and fusion. We move your breathing tube, the trachea and esophagus out of the way, blood vessels to your brain out of the way, and we go down and remove the disc, put in bone graft, and then plate and screws. That's the current standard of care for a ruptured cervical disc. Next, there is a better way, I think, and we go in posteriorly on either side of the spinal cord and into the facet joint, and put in a small cage. We do an indirect decompression. There's none of the vital structures like your airway or swallowing tube, esophagus in the way. So it's a lot less risky. Next. And if you hit one more. Yep, and then one more. You'll see if you stretch apart the two bones through the facet joint where the red cage goes, you can actually make the foramina about 20% bigger. Next. And if you follow your eye back and forth from no cage to cage on the red line, you can see the foramina with no cage small, and then over on the cage side, you can see it's actually bigger. So it really does do an indirect decompression of that nerve root in the upper part of that foramina. Next. The incisions are below the collar line posteriorly and easily hidden by a shirt. SI joint, if we go to the next slide. Yep, I'm going to play a quick movie. If you can play that, I don't know if you can hit the picture and then push play. Yep. So sacroiliac joint, that's where the spine will actually meet the pelvis and the joint right there, sacroiliac joint. And this plays for about 10 seconds or so. Normal function, the joint barely moves. It is a conduit between load from your legs, the ground, and up through the spine. Abnormal motion obviously is painful, and that's where the damage to the joint or the sacroiliac joint dysfunction comes up, very painful. The pain pattern for this particular injury is very familiar to all of you: lower back, buttock, thigh, and knee. So it's like a low back disc with a radicular component, but it is actually SI joint only. And if you don't touch the spine and you fix the pelvis, you actually get rid of all that. So next slide. I'm going to summarize this very quickly. Years ago, before MRI, we thought SI joint was most of the back problems. Then in 1934, someone published a paper saying the disc is the problem. And for the next 70 years, we operated on discs. Unfortunately, a lot of failed back syndrome. And we started thinking, well, maybe this isn't the only source of low back pain. And now we're starting to do more and more SI surgery and diagnosis. About 30% of low back pain, even with radiculopathy, is actually SI, not related to a disc. Next. So we'll skip that. We already talked about that. So again, the load pattern is through the spine, down through the legs, through the SI joint. And in auto collisions, we generally have an injury from a rear end collision with a seatbelt holding the pelvis. Rest of the body goes forward, especially if you're stomping on the brake and the pelvis is tipped, or a side impact injury causes pelvis SI problems. Next. These are the pain patterns. So on the right, you see the low back pain down the leg. That is either a disc or SI, and you have to do it on physical exam. Next. So you listen to what they say, you do the exam with several different techniques included Faber, Patrick testing, Galen's. There's a whole bunch of different physical tests. This is one of the more helpful ones for SI joint, compression of the pelvis. Next. The only way to make the diagnosis, though, is by a response to a diagnostic injection done preferably under fluoroscopic guidance, so that you know you're in the joint, a little anesthetic or steroid anesthetic in the joint, and then the response to that, did my pain go away or didn't, is the only way to really diagnose SI joint pathology. There's no MRI, CT, ultrasound, X-ray, no other test. Next. SI bone is the leader in this area or space. They've done over 50,000 SI fusions, 2,000 surgeons worldwide, but their success rates are pretty low so far because they're not really bone grafting. They're instrumenting the joint with 3 big metal rods. Next. Some of the guys are going back and doing bone grafting before they put the rod in, and that has helped. But it's an instrumentation procedure. Next. This is the side view of a person with the muscle of the hip and the pelvis, and that's the target for the 3 rods. Those things, the blue, red, and yellow, are nerves, arteries, and veins, and that's where the 3 rods go on a person. So there are some issues with implantation. Next. This is a failed SI bone patient that came to me. They had no fusion, 3 rods. Next. And I went in and bone grafted below the rods instead of trying to take the rods out, and they went on to heal. Next. Next. This is just a front view of the SI joint with all the arteries. So you can't really get there through the front of the pelvis. Next. Too many blood vessels. Next. Yep. And then one more time. Right there is the target where the SI joint surgery is done from posterior, and you can see there's no artery, nerve, vein, nothing really in the way of the access for surgery. Next. This is a CT scan of a pelvis with the bone graft on the right put in the proper position, and the one on the left is a really bad angle that wasn't put in correctly, but it still will allow that joint to fuse. So it's a very forgiving procedure. Next. You can be up to 20 or 30 degrees different. Next. And then you still get a fusion. Next. This is one where there's a bone model on the right with the graft, and then on the left, you see the white cloud. Next is just bone graft right there, no metal, and you get a good solid fusion. So it's a biologic posterior approach SI fusion. Next. This is a CT scan 1 year out. The normal joint is at the arrow on the right with a space, and the left is showing a white bony fusion between the sacrum and the pelvis. Next. Maybe next year when I do a talk on SI, we'll have an implant to talk about. I'm working on that now. Next. In-office arthroscopy, I think, is not being utilized as much as it should be. Next. We can actually do a history physical, and then maybe the next week schedule them for an in-office quick look to see if there really is a meniscal tear. And you can even, on a low value case, you can do a scope instead of an MRI and just get to the diagnosis and have pictures of the pathology for the defense. Next. And we'll skip that too. Disc nerve ablation, not facet. Next. So a probe is put into the vertebral body where the basovertebral nerve is, and that area is radio frequency treated so that it burns that nerve and gets rid of disc pain. We can also do an ablation of the facet. Next. For back pain. Next. And then stem cells, real quick, I'll run through this. The reason we do them is right here. The picture on the left with the heart symbol on the mouse is we took mouse adult stem cells and injected them into the mouse with the damaged heart ventricle, and it helped repair that. Then we took, on the right, human adult bone marrow stem cells and injected in the rat, and we still got a good response and repair. So that's kind of what started all this. We take the fertilized egg, take the inner cell mass and culture that. Next. Those are all pluripotential or multipotential cells, and you can get them from any step from embryonic, and we can do them adult, but if we treat them, we can make them pluripotential. And the treatment part is what the FDA is not happy about. So this is take the inner cell mass of that blastocyst, and then we treat them with a bunch of different things to change them into different types of tissue for reparative purposes. Next. And we can use either retroviral mediated transduction or messenger RNA, different things. That's where the manipulation is not okay at this point. Next. I'm going to try to blow this up a little bit. If you have a stem cell procedure, your general risks are seizures, manufacturing issues with the preparation. If you do it through the nose, you can get ectopic delivery of these cells to different parts of the body. If you do it in the brain, obviously you can get tissue transplanted to different areas. If you do it IV, it can be passed through the spleen and cause an immune response to then counteract the cells you just got. Or you can get a pulmonary embolism. So there's a lot of potential problems if they're not used properly. And even if they are used properly, there's a number of problems. Next. These are the countries doing studies. Next. And skip the next one. Yep. And then the disease categories, as you would expect. It's a whole multitude of different things. A lot of different countries are doing them. Colombia and India and Panama, Mexico. For various different purposes. Next. Skip that. And to wrap it up, I just thought I'd show my new dog. One more. One more slide.
That is so cute.
Last slide, next one.
Oh,
One last.
I don't see any.
Okay, well, if it's not there, it's not there.
Hey, Dr. Peterson, why do you think other orthopedic surgeons are not doing annular repairs? It seems like it makes sense.
I don't think there's a code to be paid for it is part of the problem. And it would be an add-on procedure that really is only 5 minutes. So it would have to be included in the global. I have a feeling it's a money issue, really.
Okay. And with regard to rear end accidents, I'm always been told that the low back is not at risk when you're protected by the seat, but it seems like the SI joint is at risk. So is that where a lot of the plaintiff's attorneys should be talking to their clients about and their doctors?
Yes, I think that the common notion that you're pretty well protected in your lumbar spine with a rear end collision is a bunch of nonsense. The seatbelt holds the pelvis but does not hold your spine. And as your body gets thrown forward and backward, that joint between the pelvis and the spine is at risk, especially if you're stepping asymmetrically on the brake real hard, pelvis is turned, there's an asymmetric load to the pelvis. And so I think that a lot of these people with low back stuff, it's really SI joint. And I think we miss it because anybody over 40 is going to have a positive MRI, from just normal aging. And so we see that disc protrusion and we go, oh, that must be it. And we treat that. When really, if you examine them, do the injection, you might find it's really pelvis injury.
Got it. One question that was put up, and I'll read it to you.
Sure.
What about the medial nerves as the pain generator for the facets? How do you tackle that problem?
Yeah, I'm in disagreement with a lot of the literature on some of these issues related to facet. A joint injury to me is no different than a finger, a knee, a shoulder. If you injure that joint, you need to do the diagnostic injection in the joint. And I know that's very controversial. It's not what the pain management literature says. I get it. I've been there. I've taught those classes. I understand the medial branch. The problem is if you inject the medial branch, you have to do like 3 different levels to find out that you relieve the pain at one. As a surgeon, I need to hunt with an arrow, not a shotgun. So I need to do a minimally invasive procedure. I need to localize where that pain is coming from. And I do that with selective injections. I don't think that injecting inside the joint with a little lidocaine and your pain goes away, that has anything to do with the level above. I think we're pretty much isolated to where the pain's coming from. And so I like to try and narrow it down with a little more intra-articular rather than extra-articular. Although pain management is there to get rid of the pain. So if you inject 3 medial branch nerves, then you're bound to get rid of the pain no matter which level it is. So it's just a different approach. I need to target for surgery. They're trying to treat the pain. So it's a little different concept.
Thank you very much, Dr. Peterson. I feel like, I was supposed to be a doctor. My parents didn't get lucky enough, but I feel like I'm almost a doctor today based on what you've taught us, what Dr. Chu has taught us, Dr. Curran, and I'm going to call you Dr. Olave, Matt, because you basically sound like you know what you're talking about. I think all 4 of you are amazing. Thank you very much. We've run out of time. The emails are in the chat if anybody wants to reach out to these guys individually. Thank you very much, people. I think we've learned a lot tonight. Thanks, guys.
Thank you.
Thank you.